this one. Yesterday class, we started our discussion about diabetes mellitus. We have enumerated the different types. Type 1 is the insulin dependent. They are insulin dependent because they have either severe or absolute insulin deficiency due to the selective destruction of the beta cells in the pancreas. So it might be autoimmune. When you say autoimmune, there will be attack of the immune cells in the body to the pancreas, leading to the destruction of the B cells. So that is the reason why they don't produce insulin. Now, we also have the type 2 diabetes mellitus or the non-insulin dependent na DM. The pancreas is still capable of producing insulin. However, number 1, it can be insufficient, and number 2, there is insulin resistance. So the insulin resistance might be due to some other underlying cause like inflammation due to the presence of fats and cholesterol in the body. In the case of obese people, pwede siya makakontribute. And type 2 diabetes mellitus has more of the genetic factors. So that's the more common and the most common na type of the DM. And then we have the type 3 or the others, meaning we have other causes of the increase or the elevation of blood glucose levels, just like when the person undergoes pancreatectomy, wherein the pancreas is being removed. And lastly, type 3 is called the gestational diabetes mellitus, wherein the elevation of the blood glucose level is first seen when the woman is pregnant, and that the signs and symptoms are more prominent during the third trimester. Okay, the third trimester of the pregnancy. So those were the types of diabetes mellitus. And then we also discussed the different complications. Sa type 1, we have the diabetic ketoacidosis. Due to the lack of insulin, there will be the formation of free fatty acid because the body will syempre look for another source of energy, and that free fatty acids can actually be converted into ketone bodies, which are toxic in the body. This will decrease the pH, leading to acidosis class. So that's the first complication. But for type 2 diabetes, we seldomly i-admit. We seldomly see diabetic ketoacidosis. Instead, we have the hyperosmolar na coma due to dehydration. Because remember, glucose has osmolar or osmosis na property, wherein kung asa ang glucose, just like the sodium, masunod si water. So, pwede magkaroon og dehydration. The water from the cells will go out. It will go to the blood kasi nga they are following the glucose. And that since you have a lot of blood volume na, it will go to the urine. So, daghan na urine ang ma-produce, again, leading to dehydration and leading to mental na alterations. So, just like mawala ang consciousness. Now, let's start with the different drugs that we have in the treatment and control of blood sugar level. And number 1 for that, syempre, is the insulin. However, before we go to the different insulin preparations in the market, let's discuss first insulin and its activity in the body. So insulin is again produced by our pancreas, specifically the beta cells of the islet of Langerhans. So it is actually a small protein. Its molecular weight is just 5,808. Since it is a protein, it is made up of amino acids. To be exact, we have 51 amino acids arranged in 2 chains, and they are bind together by disulfide bridges. Now, this one is a board exam question. What metal is present in the structure of insulin? The answer is zinc. So aside from the 51 amino acids linked together by the disulfide bridges, you also have zinc, 2 atoms of zinc in every 8 molecules of insulin being stored in our B cells in the pancreas. Again, that's a board exam question. Actually, before it is formed as an insulin and it can do its activity, first the pancreas will actually produce the proinsulin. It's the apoenzyme. It's not yet the complete enzyme or the complete hormone, I mean. But this one is a long single chain protein molecule which is produced by the cell but it's processed specifically in the Golgi apparatus sa beta cells of the pancreas, and further hydrolysis or further processing of this proinsulin will give us the insulin now. So that there is just removal of some segment of the proinsulin before it becomes insulin. So proinsulin class cannot really regulate the blood sugar level, kaya kailangan talaga siyang ma-hydrolyze into insulin first. Now, let's talk about insulin secretion. When does insulin secreted, when does insulin is secreted in the body? It is secreted due to a lot of stimulus or stimuli. Kailangan muna may stimuli before the pancreas will release the insulin. So what are these stimuli? We have the first one, the glucose. Syempre, if we have increased blood sugar level, then it will trigger the pancreas to also release a lot of insulin. Aside from the glucose, other types of sugar can also actually trigger the release of insulin. So sugars like mannose, even fructose, pwede sila mag-trigger sa release of insulin from the pancreas. Now, aside from our sugars, it can be monosaccharide or any other sugar. We also have our amino acids that can trigger the release of insulin like leucine and arginine. And we also have hormones like GLP-1, GIP, the glucagon, and some other vagal activity that can also trigger the release of insulin. But the number one stimulus is the glucose. However, the release of insulin can also be inhibited. And what are those things that inhibit release of the insulin? We have the somatostatin. Somatostatin is another hormone produced by the pancreas, but its action is more on inhibitory na actions. So one of that is the inhibition of the insulin release. And then we also have the leptin, another chemical substance in the body. And take note of this, chronically elevated glucose and fatty acid levels. So remember that increased glucose is the number one triggering factor in the release of insulin. However, if chronically the person's glucose level is elevated constantly, that will become now an inhibitory signal. The pancreas will stop releasing insulin. So that is the problem now for our diabetic na patient. Since they have chronically elevated glucose, if hindi siya makontrol, ayun, hindi na ma-release si insulin. More insulin will not be released from the pancreas. Now, aside from that, if the person has high fatty acid level, daghan og triglyceride, there is increased triglyceride in the body, then that will also trigger the inhibition of the release of the insulin. So magsanga-sanga na dayon, and then it will complicate everything. It will complicate the condition of the patient. Questions so far about insulin and its release? Wala? Okay. So, let's have the insulin degradation. If insulin is produced in the pancreas, insulin naman now is being destroyed or degraded either in the liver or in the kidneys. This is where we destroy and excrete our insulin. Okay? So hindi siya forever. Walay forever. Even our cells die. So insulin also is being destroyed. Liver and kidneys. So that is why we need a constant production or formation of insulin. Now we have circulating insulin that will take its action in regulating the blood sugar level, in which the normal values or the normal level is 5 to 15 microunit per ml, or if we use the picomole per liter, it should be 30 to 90. However, during meals, since during meals we consume a lot of fatty foods and most likely the carbohydrate-rich foods, then the circulating insulin will actually be increased into 60 to 90 microunit per ml, or 360 to 540 pmol per liter. So dito na siya pinakataas during meals. Mag-peak ang circulating insulin. Okay? And there are also agents that will either increase the activity of insulin or will inhibit its activity. So hormonal agents, just like glucocorticoids, if you are this patient who consumes a lot of glucocorticoids, like for asthma or for allergic conditions, it will actually be an inhibitory na agent for insulin's action, kasi it will lower the affinity of the binding of insulin to its receptor. That is why if we study corticosteroid, one adverse effect of corticosteroid is hyperglycemia, or it can lead to diabetes mellitus. However, growth hormone in excess, if we have in excess na growth hormone, it will increase the insulin affinity. So they have the reverse action compared to the hormonal agents. Okay, now let's talk about the effects or the activities of insulin to the different parts of our body. Let's start with the effects of insulin in the liver. So the first one is reversal of catabolic features of insulin deficiency. So that's number one, inhibits glycogenolysis. Insulin will inhibit the lysis of glycogen so that it will not be converted into more glucose. We don't need that if we have a lot of insulin, no? Di natin gusto na daghan taog blood glucose. So, i-inhibit niya ang glycogenolysis. When you say catabolism, diba, it's the one type of metabolism wherein we degrade bigger molecules into smaller ones. So since glycogen is a big molecule, if it is degraded, it will release a lot of glucose. So insulin is inhibiting that process. Insulin also inhibits conversion of fatty acids and amino acids to keto acid. So this is the reason why if we have insulin deficiency, the type 1 DM patient will experience diabetic ketoacidosis kasi nga wala ng insulin that will inhibit the conversion of these fatty acids to keto acids. And aside from that, insulin will also inhibit gluconeogenesis. Remember, the gluconeogenesis is the process of converting non-sugar sources to glucose. So just like the amino acids in the body can also be converted to glucose to have a new source of energy. So insulin will inhibit this process. However, insulin also has anabolic action. So, di ba, if catabolism is the degradation of a large molecule to a smaller one, anabolism is the other way around. We have smaller particles or smaller molecules combining together to form a larger one. So what are the anabolic action of insulin? We have promotes glucose storage as glycogen. So instead of having a lot of glucose in the blood, it will trigger glycogenesis. That's the reverse of glycogenolysis. The other one, a while ago, is glycogenolysis. Mag-inhibit siya of conversion of glycogen to glucose, but it will promote glucose storage as glycogen in the liver. We call it glycogenesis. And aside from that, insulin will increase triglyceride synthesis and VLDL formation. Okay, increase triglyceride synthesis and VLDL formation in the liver. It's an anabolic process, meaning you are making a large molecule from the free fatty acids. So that is how it inhibits the diabetic ketoacidosis also. Instead of having a lot of free fatty acids in the body, it will be converted and formed into larger molecules like the triglycerides and the VLDL. So those are the effects of insulin in the liver. Now, how about in the muscles? In the muscles, actually, insulin is very important because it increases protein synthesis for our muscles, including the amino acid transport and the protein synthesis which takes place inside the ribosomes. And aside from that, it will also increase glycogen synthesis in the muscle. So not just only in the liver, but also in the muscle. Glucose in the blood will be transported and will be processed to be stored as glycogen, which is a bigger molecule. Next is the effect of insulin in adipose tissues. So sa adipose tissues, actually insulin, na-mention ko na siya kanina, it will increase triglyceride synthesis and also the storage. So the purpose of this is to decrease the free fatty acid circulating in the body that will be converted into toxic ketone bodies. So is to store siya in the adipose tissues as triglycerides. Ang problema nato anak kay mutambok man ta if i-store nato ang atoang triglycerides in our adipose tissues. And insulin will also inhibit intracellular lipase. We have lipase not just in our intestine to get the triglyceride from the chylomicron. We also have lipase inside the cell that supposedly will degrade triglyceride to free the fatty acid. So we don't need that also if we have lipase inside the cell. Inhibit magud na siya ni insulin para walay free fatty acids. So those are the important actions of insulin in the liver, in the muscles, and in our adipose tissues. Questions so far? Sa action ni insulin. This one is endogenous insulin, the insulin being produced in the body. But if the person is diabetic, then we can give insulin na preparations available in the market. So let's discuss their characteristics now. Kung wala pa mo nag-ila-ila ni insulin na present in the market. Let's have this principal types and duration of action of insulin preparations. Our insulin preparations in the market are categorized or classified according to whether they are long-acting or short-acting. So we have here the first one, rapid-acting with rapid onset and short duration. Rapid-acting mabilis ang action niya. Pag-inject, mag-take na siya agad ng action pero short lang. So short-lived na insulin preparations. We also have short-acting, so it has nothing to do with the onset. Short-acting insulin lang yun siya, short duration ang iyahang action. And then we also have intermediate acting and long-acting with slow onset of action insulin. So take note of this. If the insulin is injected, like we have rapid acting and short acting insulin, their characteristic, when you look at the preparation, they are actually clear solutions. Their pH is neutral, and then they contain small amount of zinc. The purpose of that is for the stability and shelf life of the preparation. So just like the endogenous insulin, rapid-acting and short-acting insulins also have zinc. But the purpose is for stability and the shelf life of the product. Now, how about the intermediate acting NPH insulins? If it is NPH insulin, it is intermediate acting. What is their characteristic? They are turbid suspension, unlike the rapid-acting na clear solution, but their pH is also neutral. But instead of zinc, the substance that is added here for the intermediate acting insulin is the protamine in phosphate buffer. Okay, and lastly, the insulin glargine and the insulin detemir are our long-acting insulins. Again, our glargine and the detemir are long-acting insulin. How do we describe them? Just like the short-acting insulins, they are clear. And they have soluble, long-acting na mga soluble substances. That is just added to make it long-acting. Itong mga long-acting solubles natin. So let's discuss them one by one. Kasi when you say insulin, hindi lang isa ang insulin natin in the market class. And it is very important for us to know them one by one and when to give them sa patient. Di pwede nga, basta insulin, tagayin na siya insulin. No, that's not the case. Kailangan na to mabalaan kanus siya ginahatag. So let's start with the rapid-acting insulin. Rapid-acting, they have rapid onset. So they will take their action immediately after administration. But most of them have short duration of action. So we have the Insulin Lispro. By the way, the ones inside the parentheses are the brand names. They are the brand names class. We have the Insulin Lispro, brand name is Humalog. Insulin Aspart, we have the Novolog. And the Insulin Glulisine, the brand name is Apidra. So get to know them one by one. Now, since they are rapid-acting class, they are used to prevent postprandial insulin increase. When you say postprandial, paghuman o kaon. Diba? When we eat, right after eating class, our blood glucose level will actually shoot up. Mag-i-increase talaga yan, especially if we consume carbohydrate-rich food. And that will be a difficult case for our diabetic patient. For us na we don't have diabetes class, actually it's normal na mag-increase ang atuang insulin after eating. But since we have enough supply of insulin and that we don't have insulin resistance, so it's okay for us. But for people with diabetes, this will be a problem when after eating they don't have insulin and then mag-increase ang ilahang blood sugar level. So these rapid acting insulins are provided for them, administered sa kanila, pwedeng before eating or pwedeng after eating, just to prevent the postprandial increase of the insulin. So this will actually mimic the normal endogenous prandial insulin secretion. Diba? After when we eat, automatic si pancreas magre-release naman talaga siya ng insulin. So pwede siya i-take before meal. So, ang problem with our class, with our rapid acting insulin, kung katulog ka mo kaunsay sa kadaw, syempre katulog man yun, mamahaw, maniud to maning hapon, katulog pod mag-inject ang patient, ani. Again, 3 times a day pod mag-inject og insulin ang patient if we use our rapid acting insulin, because remember they are short acting also. So they will just be there for a short period of time to regulate the blood sugar level of the patient. Now let's discuss them one by one. We have the Insulin Lispro. Actually, it is called Lispro because of the disarrangement or rearrangement. Let's call it rearrangement of the different amino acids found in insulin. Diba? Insulin has 51 amino acids. For the Insulin Lispro, there is the reversal of the position of the proline and the lysine in the amino acid sequence of the insulin. So that is why tinawag siyang Insulin Lispro. From the name itself, you have to know what amino acids are being reversed. The proline and the lysine. Itong mga insulin preparations natin in the market are product of recombinant technology. So later we will discuss that also, how they produce insulin or these insulin preparations in the market. Now the second example of the rapid acting insulin is the Insulin Aspart. Okay, Insulin Aspart. Now what happened here? There is the substitution in the B28 proline with a negatively charged aspartic acid. That is why it is called Insulin Aspart. B ha, kasi na-mention ko kanina, when you say insulin, meron tayong two, balikan natin yon sandali para hindi makalimutan. Take note of this. The insulin has two chains. So the A chain and the B chain, and they contain 51 amino acids arranged and linked together by disulfide bridges. Now for the Insulin Aspart, it's on the B chain in which the proline in the 28th position is being substituted with aspartic acid. So it's called Insulin Aspart. And lastly, the insulin glulisine. What happened here? There is substitution of the asparagine for lysine at the B3. So chain B pa rin on the third position, and glutamic acid for lysine at the B29. So it is called glulisine. Glulisine, insulin glulisine. Now, the rearrangement and the substitution of these amino acids make this insulin preparation rapid acting. Okay, again, rapid acting, so that they will take their action immediately after administration. However, the rearrangement and the substitution will make this insulin preparation short acting. So, but our goal here is rapid acting ha, para after eating, there will be immediate control of the blood glucose level. Questions so far about our rapid acting insulin? Then dyan ang hindi naintindihan. Wala. May pangkana. Si Isobel, sigig ka putol. Sigig ka disconnect. Kagaya na pa na siya gawa-sulod. Wala, nasabtan to. Ang ato ang rapid acting ha. Now let's move on to our short acting insulin. They are not rapid acting. Meaning, they will not really take their actions immediately after administration. However, just like our rapid acting insulin, they have short duration of action. So, if we have short duration of action na insulin, then ang result is we will administer this 2 to 3 times a day or more than that, depende sa insulin nga gihatag. So we have regular Novolin R, the brand name is the Novo Nordisk, and the regular Humulin R. So itong mga regular insulins, they are called regular insulins kapag may nakita kayong insulin preparation and then may nakalagay regular insulin, automatic ha, they are short-acting insulins. Now itong mga regular insulins natin, they have, remember, zinc in their structure to make them stable and for their shelf life also na hindi sila agad masira. But just like other insulin preparations, these are prepared using recombinant technology or recombinant DNA technology. Now, how do we administer regular insulins? They are administered 30 to 45 minutes before meal. Before magkaon ng patient, pwede gihapon sila na to prevent postprandial increase in the insulin pag human og kaon. But what is the board exam question here? The board exam question is, for regular insulin class, this is the only insulin preparation in the market that can be administered intravenously. Remember, how do we administer insulin? Sino dito yung nakatry na mag-administer ng insulin or nakapag-observe sa someone na nag-administer insulin? Paano ina-administer si insulin class? Anyone? Paano tayo nag-administer ng insulin? Orally? Or anong klaseng route of administration ba si insulin? Manawag ka? Wala pa yung nakatry mag-inject og insulin or nakapag-observe paano gi-inject si insulin? Yes, Claire, paano gi-administer ang insulin? IP, what's IP? Intraperitoneal? No. Insulin is not administered intraperitoneally. Sa may tummy, how do we call that? Yes, sa stomach banda gina-inject. Pwede. Pwede mapud sa braso. Pwede pud gani sa thigh. Yeah, using an insulin pen roselle. Pero what route of administration is that? IM? No. Okay, very good, Sarah. It's subcutaneous. Take note, do not forget. Our insulins are administered subcutaneously. When you say subcutaneously, it's after the skin, it's between the skin and the fats. Okay? So, dili po siya IM ha, kay dili na siya makaabot sa muscles. Remember, kung nakita ninyo ang needle for insulin class, it's very small. So, dili gid na siya makaabot sa muscles. It's just on the fats, subcutaneous. Okay? So most of them are subcutaneous. Kaya naging board exam question si regular insulin because this can be administered intravenously. Please remember that. So dili lang siya sa tiyan ha. Actually, when we inject insulin, we look for body parts that are rich in fats, in adipose tissues. Mao na siya kung napansin niyo sa tiyan, syempre kay sa tiyan daghan og adipose tissues. Pero pwede po siya sa braso, especially this part here na daghan og fats, and even sa thigh na daghan pud og fats. So pag mag-administer mo pohon og insulin, mo na inyong buhaton. Nangita mo og body parts na rich in adipose tissues kasi dapat subcutaneous. So ulito na ako, ang inyong tandaan for regular insulin, mga short-acting insulins natin can be administered intravenously. Now, how about the intermediate acting insulin? So, ang kanilang action, ilahang duration of action is longer compared to the shorter ones. Pero, dili pod sila comparable to our long-acting insulin. So, we have here NPH Humulin N and NPH Novolin N. And actually, we have pre-mixed insulins. Minimix nila ang short-acting, ang rapid-acting, and ang intermediate-acting insulins natin. So just like this, Novolin 70 NPH, NPH is the intermediate-acting, and 30% na regular. And then we also have Humulin. Humulin is another brand, 70 NPH and again 30 regular. And we have 50-50, 50 NPL na intermediate, and then the Lispro. Diba, remember the Lispro is a rapid-acting insulin. We also have 75-25. 75 na NPL had the intermediate and 25 na Lispro. And 70-30 NPA and the Aspart. So why do they mix this one? Especially for the rapid acting. That is to have the rapid action, the rapid onset, plus the prolonged duration of action. That's the reason and the purpose of premixing the insulin. By the way, NPH is neutral protamine hagedorn or isophane insulin. It has delayed absorption and therefore delayed ang kanyang onset of action. But the duration is intermediate between the short and the long-acting one. NPL is neutral protamine Lispro and NPA is neutral protamine Aspart. The NPH is neutral protamine hagedorn. All of them are intermediate acting insulins, but they can be mixed with the shorter acting insulin and the rapid acting insulin to have the rapid action and to prolong the duration of action. Okay, now let's move on to the last preparation. We have here the long-acting insulins. In the market, we have the insulin detemir and the insulin glargine. The ones in the parentheses are the brand names. Actually, if you work in a community pharmacy, the Lantus is very sikat. At may mangita na gani na og Lantus, you have to dispense a long-acting insulin, which is called the insulin glargine. Wait lang ha. Okay, and let me add, kasi this one is a new drug. Hindi ko siya nasali. We have another preparation in the market that is also a long-acting insulin. We call it insulin degludec. I forgot the brand name though, so I'm not really good with the brand names. So you can research for that. But the name of this another long-acting insulin is the insulin degludec. This is long-acting, so they are administered even once a day only. So prolonged ang ilahang action angtod sa tibuok adlaw. This can provide insulin for the use of the patient in regulating the blood glucose level. Now, another board exam question, why insulin glargine is widely used nowadays? It is called the peakless insulin. Meaning, di ba sa inyong class, sa inyong biofarm, pag naga-drawing mo sa AUC, area under the curve, di ba, it looks like this. Ay, dili siya pantay, but it looks like this. It's like a bell. And the area under this curve is the time, the concentration where the drug takes its effect. So may effect ang drug dyan. And this one here is the Tmax here, and the Cmax. Okay? The maximum concentration and the time wherein you can have the maximum effect or the peak of the drug. This is true for most of our drugs. May peak talaga sila, may time sila kung kano sa sila ma-achieve nila ang peak plasma concentration and ang peak nila na effect. But for insulin glargine, this is actually a peakless insulin. If you administer this, the graph will just look like this one. So wala siya. Plateau lang. There is a time na magkaroon siyang maximum na concentration pero mag-ano lang siya, mag-plateau lang siya. Ano siya nga, peakless insulin, and that is the reason why it is also a long-acting one. Ma-prolong ang iyahang action before siya ma-excrete. So we don't really have a peak for this if we look at its pharmacokinetic profile. That's insulin glargine. And the insulin detemir and the degludec are recently discovered and developed long-acting insulin. So, anong ginagawa nito for our diabetic patients? I remembered sa ako ang papa, I think na siya apidra. That's the insulin. What's the generic name again of apidra? It's glulisine. Yeah. So my father has apidra. So this one is a rapid-acting insulin. This is administered 3 times a day sa iyaha. So before meals, before siya mamahaw, maniud to, o manihapon. And then also, naa siya deglodec. The insulin deglodec, which I forgot the brand name. This is the long-acting insulin na ina-administered once a day. Okay? Once a day ito. So therefore, akong papa before siya namatay, nag-inject siya insulin 4 times a day. So imagine the suffering of injecting subcutaneously 4 times a day. So yun yung ginagawa para sa insulin niya. Pero pen man itong insulin, no? So meron itong dose class. So after some time, ganun pa rin, 4 times a day total, pero nung na-control na ang kanyang sugar, nagbaba na ang dose sa iyahang mga insulin. Ang katong pen class sa end ato, na ato'y ginatuk-tuyok na ginaset nato ang dose na i-inject. Okay? So that's how we administer our insulin. Any questions so far? What time is it? Before ta mag-end? So ang insulin production is through DNA recombinant technology. Anong ginagawa nila? They'll have the DNA of the human insulin. So human insulin kasi dati ang ginakuha natong insulin is the bovine or the pig. So kaya lang may problem tayo with the immune response since it's a non-self insulin, and at the same time we have religion na mga consideration. So that is the reason why ang ginagawa na ngayon, the insulin is coming from human, pero paano nila pinapadami? They are inserting the human insulin to either the E. coli or the yeast na hindi ito nagkokos na sakit ng mga strains and then pinapadami nila itong mga microorganism, and as this E. coli and yeast multiply, the DNA inside will also multiply, and kukunin nila yon, they will extract the proinsulin, process it to make the insulin. That's how they do the recombinant DNA technology. And for the insulin delivery systems, na-mention ito kanina ni Roselle, we have the portable pen injectors. That's how we dispense our insulin, naka-pen, and may mga unit sa loob. I-adjust na lang natin how much na unit yung i-inject natin sa patient. Pero yung needle nitong pen na ito class, pinapalitan bawat injection. So if you are going to dispense a pen na insulin, you also have to dispense supply for the needles. Kasi kailangan, diba, sterile. So kung na-inject na siya, hindi na yun siya sterile. You have to replace the needle. And we have continuous subcutaneous insulin infusion devices or the CSII or the insulin pumps. Ito yung na-mention ko sa belt ni Gary V. I think I mentioned yesterday na sa belt ni Gary V, meron siyang pump that will continuously give him the insulin. Since type 1 DM siya, insulin dependent siya. So I think dira lang ko mag-end. It's 10:27. Any questions so far? We will continue with the regimen of insulin on Monday. And after the insulin will be the OHAs, the oral hypoglycemic agents. No questions?